Hi, this is Sam. Welcome to my asthma case study. Our patient is DOMINIQUE WHEEZE. She is an 8-year-old Caucasian girl, 51 inches tall, who was diagnosed with asthma about a year ago. She was at the time prescribed a short-acting beta agonist albuterol inhaler, which she is now using 2 to 3 times per day for breathlessness, and her peak flow meter that she was taught to use at home is regularly coming back with values of 80 to 85% of her predicted peak expiratory flow, which, according to her height, is going to be 254 liters a minute. When asked why she's using her albuterol or what she's using it for, her father responds, for episodes of breathlessness. However, Dominique's pretty lucky. Her albuterol always takes care of her symptoms within 10 or 15 minutes. She hasn't had any exacerbations that were bad enough that the albuterol didn't touch it, or that were severe enough that she had to go to the ER. In terms of current presentation, while she has no complaints of chest tightness, no trouble breathing, she's talking normally, she does have a persistent dry cough and a mild expiratory wheeze noted upon auscultation. Nothing else out of the ordinary. Her HPI, her father states, tells us that both her mom and her older sister have asthma. So when a year ago Dominique started complaining that she couldn't breathe at recess, that rang a bell for him. They brought her into the office where a diagnosis of asthma was made. Her cough, he says, is almost constant, but her other symptoms tend to be brought on or worsened by particularly cold weather, exercise like gym class, running around at recess, and worse during allergy season. Dominique says, when I feel bad, no matter how wide I open my mouth, it still feels like I'm breathing through a straw, and my chest just doesn't want to breathe. So it's really important before we go about treating her current symptoms to confirm that we agree with the previous diagnosis of asthma. According to the EPR-3, which is an amazing set of guidelines that was produced, the third version was produced in 2007. It's 440 pages of really good time. But it goes into things like diagnosis, treatment, management. It has guidelines for all sorts of age ranges. So it's a really valuable use of your time if you've got it. But one of the things that it says is that the diagnosis for asthma is made using a synthesis of information from her current clinical picture, her history, as well as values such as spirometry. You can go and you get blood types for things like eosinophils, but most people can get to the diagnosis without using that. So we're glad to do it. So some key things. First, to confirm the diagnosis, you need to establish that the patient does or has experienced episodic symptoms of airflow obstruction. 2, that these symptoms are reversible. And 3, you need to be able to exclude other possible explanations for the symptoms. And as we're going to get to in a second, for kids, there are a lot of alternatives. However, asthma is, from everything I read, the most common cause of airway obstruction in kids, or obstructive airway disease, I should say. So some key indicators of asthma, again, according to this EPR-3, are a history that includes a cough that worsens at night, recurrent wheezing, difficulty breathing, and or chest tightness, all of which Dominique is experiencing. And in particular, these are indicative of asthma when they occur or worsen with exercise, viral infection, or exposure to allergens, such as fur, dust, mold, smoke, pollen, things of that nature. They also can be exacerbated by changes in the weather or certain times of the menstrual cycle. Like I said, the differential diagnosis for asthma in kids especially includes a lot of different things. Everything from allergic rhinitis and sinusitis, mechanical obstruction, vocal cord dysfunction, heart disease, tumors. The last 2 heart disease and tumors, since most heart disease at that point is due to structural abnormalities, and tumors, obviously, they would be visible upon imaging. Mechanical obstruction and vocal cord dysfunction both characteristically will include an inspiratory wheeze, which certainly asthma can have, particularly when it's very severe. But that's kind of something that would make you look elsewhere in terms of causes. In Dominique's case, because of her family history, the episodic nature of her symptoms, the fact that they are reversed by using her albuterol, so her SABA, all pretty indicative of asthma. The last thing that's really important to a diagnosis of asthma is spirometry. Now, at home, she's going to use a peak flow meter just to keep track of that herself. However, upon her initial laboratory testing, and here today, we can see that her her FEV improving after the albuterol is a really good indication that when you're relieving the inflammation, you're relieving the symptoms. So yeah, we pretty much agree that it's asthma. Now that we agree that she does have asthma, we have to come up with her goals for therapy. So the EPR3 says the 3 things that we want to do are first to reduce her impairment. And to have successfully done that, we will have decreased her use of her albuterol to 2 or fewer days per week. We'll get her to near normal pulmonary function, so close to that 254 liters a minute peak flow that we want to see. And lastly, we want to get her doing normal activity, so enjoying her recess and exercise and playing with friends without having to stop for her symptoms. So that's reducing impairment. The next thing we want to do is reduce her risk. So we want to prevent the recurrence of exacerbations for her. Again, reasons to use her albuterol. And we want to decrease her number of emergency department visits, which, granted, luckily she hasn't had to do so far. We also want to prevent the progressive loss of lung function and the restriction of lung growth that can occur in kids with chronic uncontrolled asthma. Lastly, the EPR3 also recommends that we want to get the patient involved in planning their goals for care as much as possible in kids as young as 10 or even younger, depending on their maturity level. So when we ask Dominique what she wants for herself, she says, "I want to feel like I can breathe, and I want to play with my friends." Clearly, those are things that are not happening right now, so indicating a high enough risk of a level of impairment. So what do we do? The EPR3 has many kinds of guidelines for the diagnosis, classifying the initial severity upon diagnosis of asthma, but the one that we're going to use here is the one for controlling an existing diagnosis of asthma and adjusting therapy. They are divided into kids 0 to 4, children 5 to 11, and adults and kids greater than or equal to 12 years of age. So we're right in that middle group right here. And according to this set of guidelines that they have, this is right from the EPR3. What's interesting is that Dominique's use of the albuterol several times per day actually puts her under the category you see on the far right of very poorly controlled. She's having symptoms throughout the day, which you could definitely count her persistent dry cough, a little bit of a wheeze after a walk from the parking lot, but she's speaking normally and acting pretty normally at this point. So that puts her under the very poorly controlled. And if you look down, the recommendations for that are to consider a short course of oral systemic corticosteroids, which we certainly could do. However, given that she seems okay to function normally, her symptoms are always relieved by albuterol. Personally, I don't think we're there yet, but according to these, it would definitely not be a bad decision. We also are going to step up 1 to 2 steps on the stepwise treatment, which we'll see on the next slide. Lastly, we're going to reevaluate her in 2 weeks to make sure that whatever steps we do take are working. So, this is the stepwise approach for managing asthma in kids 5 to 11. This is the next set of guidelines suggested by the EPR12. Currently, you can see that Dominique is being treated at step 1. It's just a SABA PRN albuterol as needed. However, we don't want to be using that 2 to 3 times a day. And with controlled asthma, she'll be using that 2 or fewer times a week to treat her symptoms. You can use it more than that for preventative before gym class, for example. So according to the recommendations on the previous slide, we're going to step her up 1 or even 2 steps. Now, because she's relatively stable, her symptoms are controlled when she does take her albuterol, I would lean towards just stepping her up 1 step. But you could always go 2 to step 3. Under step 2, the things that we are allowed to do are a low-dose inhaled corticosteroid. Alternatives to that are cromolyn, a leukotriene receptor antagonist, nitocromil, or theophylline. Pretend I know how to pronounce those ones. But according to the EPR3, the preferred is the low-dose inhaled corticosteroid. So we'll go over some options for those. If we were to proceed to step 3, the preferred treatment is either a low-dose ICS, inhaled corticosteroid with a LABA added, or a medium dose inhaled corticosteroid. So these are those therapeutic options we just discovered. A cool thing that I learned among the 440 pages are in step 3, which I actually don't think is necessary in her case, although it's certainly an option, and it will definitely be an option if she comes back in 2 weeks and the low-dose inhaled corticosteroid that we're starting her on today hasn't really started helping. We'll definitely be going to step 3 at that point. But what I learned was, for patients whose main problem is impairment, where it seems like Dominique's is, the preferred step 3 out of the 2 preferred options would be a low-dose inhaled corticosteroid, just adding a LABA to that instead of stepping up to the medium-dose inhaled corticosteroid. If our main concern with her had been risk, it does recommend going to a medium-dose inhaled corticosteroid, but the data that I found said that an increase of 4 times the dose was necessary to decrease the risk of exacerbations. So, especially in kids, increasing that risk of inhaled corticosteroids is a little scary. But I got a little sidetracked. That's not where we're going. We're going to step 2, a low-dose inhaled corticosteroid. On the next slide, you can see some options for those. They are beclomethasone, which is QVAR, budesonide, which is Pulmicort, flunizolide, which is Aerobid, fluticasone, which is available as FLOVENT, or our annuity Ellipta, and triamcinolone. A few things about a couple of those. The fluticasone seems to be the most popular. Everything that I found said that it was very effective and very safe in low to medium doses. The budesonide and the beclomethasone are both equally effective, somewhat less popular, but absolutely options for Dominique. The flunizolide, the Aerobid, it said, what I found said that it had fewer side effects, but that's also less effective. And our last option that's probably not recommended would be the Asthmacort, which is less effective and has more side effects. So the annuity Ellipta seems to be a newer drug. It's one version of fluticasone. It's a fluticasone furoate. It was only approved in 2014, so there's not a ton on it. However, the advantage of that is that the dosage is once per day. It's in a discus, so a dried powder inhaler, very easy to use, and about the same cost as the FLOVENT. The FLOVENT, which I would choose in this case, is available both in a discus or in a traditional inhaler, which I would go with in this case simply because she already successfully takes an inhaler in her albuterol. So here's more information on that. So like I mentioned, FLOVENT is available in a traditional meter dose inhaler as well as in a discus, so a dry powdered inhaler. In this case, I would go with the traditional inhaler, even though Dominique is a little bit young. She's been using the albuterol successfully with a spacer. It's another thing that I forgot to mention earlier in this presentation. I would absolutely double check that she's been using that albuterol successfully through having her show me exactly how she uses that inhaler with the spacer. The reason I would go with that is just the cost is significantly more for the discus. So why do that if you're getting the same med for less money and she's shown that she can do it successfully? So her dose of that is going to be 2 puffs. FLOVENT, the traditional inhaler, is available in 3 different strengths. We're going with the lowest, which is 44 micrograms per actuation. That's twice a day. The pharmacology on the FLOVENT, which is a fluticasone propionate, so as an inhaled corticosteroid, its exact mechanism of action isn't fully understood, but it results in the inhibition of multiple inflammatory cytokines and subsequently decreases the inflammation in the affected airway. Now, along with the albuterol, which is going to decrease the bronchospasm, by decreasing the inflammation, we're going to address the 2 elements of the reactive airway disease, that is asthma. So that's handy. In terms of pharmacokinetics, FLOVENT is absorbed through the lung and the airway mucosa. It's metabolized in the liver. So it is a CYP450 drug, something to think about. There's very little systemic effect, though. It's excreted mostly through the feces, with about 10% through the kidneys as well. For drug interactions, all of the CYP450 drugs, including some antivirals, antifungals, other steroids. What you're going to want to watch if at some point she needs to be on any of them is the effect of the fluticasone, because it can increase the level and increase the risk of systemic corticosteroid effects, resulting in things like Cushing's disease and adrenal suppression. It is worthy to note that it's contraindicated to give this medication alongside desmopressin, should the need ever arise. Just some further education about this new medication that we're adding for Dominique. Some adverse effects that she should keep an eye out for along with her family are oral candidiasis, so thrush. You're going to keep an eye out for upper respiratory tract infection due to the localized effects of the corticosteroids and their potential for immunosuppression. In addition, if she hasn't taken anything like this in the past, you could always keep an eye out for hypersensitivity. Things to know about this medication. You cannot overstate the importance of making sure that Dominique and her family understand that her FLOVENT is not an asthma rescue medication. She needs to still use her albuterol for immediate symptom relief and to continue follow her asthma action plan, which we are going to update on the next slide. Second, it's a big concern with a lot of people, especially parents who have looked it up on the internet, the concern of growth suppression related to prolonged use of steroids in kids. However, at low to medium doses, they're very safe. Any growth suppression is limited to less than a centimeter. That takes place generally over the first year and is not progressive. Another study that I saw said less than half a centimeter. So not generally a huge concern, especially at low to medium doses. Lastly, if she does develop oral thrush, she can just rinse her mouth after every use twice a day, and just to be sure to regularly clean her spacer. You can always tell her to do this, to rinse her mouth anyway with every use, but the rate of oral thrush is less than 30%, can even be less in clinical practice. So really worth hammering home, especially if she does get it, but not a huge concern. So this is Dominique's new asthma action plan. So Dominique's green zone, this is her everyday use of her control medication. That's the FLOVENT that we've just been talking about, so the fluticasone propionate. She's going to use that 2 puffs twice a day as a baseline. In addition, because her asthma is exacerbated by exercise, she can take her albuterol, 2 puffs with a spacer, before things like gym class, or if she wants to run around at recess and she knows it's going to be exacerbated. So she can do that as long as her peak flow is above 203, which would be 80% of her personal best, which is conveniently the same as the predicted value for her age of 254. She's all set in that green zone. Now her yellow zone, the peak flow between 50 and 80% of her personal best, so 127 to 203. She's also in the yellow zone if she has any of these things that are listed. This is also a guideline from the EPR3, by the way. So the first sign of a cold, because that's going to exacerbate her symptoms, when she's being exposed to a known trigger. So if she walks into a house on a play date and notices that someone has smoked in there, she can go right ahead and take a dose of her albuterol. So that is also the lower dose. It's 90 micrograms per actuation, and she's doing that twice, so she's getting 180. She can take that as often as every 4 to 6 hours. However, she definitely wants to call the office if in any of the following cases. So if her albuterol relieves her symptoms, but it doesn't last the 4 hours. If she stays in the yellow zone for more than 12 to 24 hours, despite using that albuterol a couple of times. Basically where she has been, she's been living in the yellow zone. Or in the future, if she finds herself using the albuterol more than 2 days per week. Lastly, the red zone, that is where you need to, at the minimum, call the office, and if you need to go to the ER, call 911. So anything under 50% of her personal best for peak flow. So that would be anything under 127. If she's not breathing, or if her breathing doesn't improve when she takes her albuterol, that's when you need to call go. Have Dominique and her parents use their judgment. At any rate, if she doesn't, if she takes her albuterol in that red zone and her symptoms improve, she still needs to call because she got below 50% of her peak flow, and that means something's going wrong. We're going to need to look, we're going to go back to that, those guidelines for controlling your asthma and potentially step her up. She also, if she does have to go to the ER, recommended to give us a call within 2 days. So that is basically it. Once Dominique and her father understand this new action plan, they can go pick up their medicine. We're going to make an appointment for 2 weeks to see how this new med, the step 2 low-dose inhaled corticosteroid, is helping her with her symptoms. That's it. Thanks. Just kidding. My references are on the next page. If you have time or are just weirdly into asthma, I really do recommend reading the EPR3. It's kind of interesting. There's a lot of information in there, more than any one person I think can master, but worth the read if you've got the time and the interest.